Thank you for inviting me and having a chat with me about the care of older people. I am a geriatrician and I specialize in comprehensive geriatric assessment. What that is the care of older person as a whole. When I was training as a geriatrician, we were encouraged to choose subspecialty within the geriatrics, whether you will be a geriatrician looking after patients with dementia or Parkinson's disease, maybe geriatrician specializing in cardiac care. And I said, I want to do it whole. And back then, there was no such a thing. And of course, I persevered. I said I wanted to be a general geriatrician and do the whole thing for my patients. And of course, in the last few years, you might be familiar with the way things are going in United Kingdom. Frailty has become a big thing. And of course, how can you look after a patient with frailty? Only as a whole. So that's what I do. In my hospital, my role is also a stroke consultant, and once a day I look patients in a rehabilitation community hospital as well. One of my main approaches to the patient safety, especially when it comes to medications and things like that. When the patient is admitted acutely to hospital, my approach is this patient is in hospital and unwell this way because of a side effect or one of the medications they are on. That's a starting point, unless proven otherwise. So therefore, medication review, a thorough medication review, and in vast majority of patients, this results in a lot of deprescribing. In other words, finding out medications which they no longer need is a final result of that. So admission to hospital is a side effect of medication unless proven otherwise. So that's a first approach. And of course, everything else comes from that. The second important thing to mention is personalized approach to patient safety. And of course, within the NHS, we have so many safeguards. There are the guidelines, safety netting for patients with falls and for patients with confusion, how to prevent MRSA and hospital-acquired infections. I can go on a whole day about various patient safety netting put in place within the NHS to protect our patients. But what they're all missing is a personalized approach to a patient, because you can have a full prevention guidelines, but they will be completely useless and your patient will still fall if you do not take into account a personal circumstances for that particular patient. We grow older, and either because of genetic problems or environmental problems, or maybe living not 100% healthy lifestyle, we develop various medical problems. And in there, usually in our 50s and 60s, we go from one professional to another professional, addressing our problems, treating our cardiac concerns and lung concerns, and we end up with different medications from different healthcare professionals treating all these concerns. And guess what? They're doing an amazing job because the population is aging and we somehow get into our 80s and 90s. But the very medications which made you to come into your 80s and 90s, unless they're reviewed and medication doses are adjusted, or the new medications are switched or discontinued, the same medications who helped you to age and come into your 80s and 90s start harming you, because the side effect profile of these medications in your 80s and 90s start outweighing the benefits to be gained. So it is so important. When I talk about polypharmacy and deprescribing, I'm not going and slating my colleagues who prescribed all these medications. In fact, I am thankful to them. I say, thank you, cardiologists, thank you, pulmonologists. You actually help these people to come into their 80s and 90s. And as a geriatrician, I have a job. Thank you. But we need to regularly review these medicines because physiologically, the liver and the kidney, which are the main organs which metabolize these medications, they are aged, their circulation is not the same, they are diseased, so the medications have to be reviewed, and some of them discontinued. Now, I have to go into a little bit into NHS history to answer this question. And I think the problem we have, especially in this country with the NHS, when it was established, it promised to look after you from cradle to grave. And by doing so, it more or less disempowered the patient over many, many years. NHS has been so brilliant, doing literally everything for you. And the NHS patients are brilliant. They actually do follow, majority of them do follow everything you tell them to do. I can tell that about my geriatric patients for sure. They're very, very good patients to me. However, the years went by, the NHS has changed, the demands are increasing, and we do not have the workforce now in numbers and quality and quantity to look after a fast aging population with a much more complex chronic disease. So the time has come probably 20 years ago, but we're not talking about it enough for to hand over that caring back to the patient themselves. And what you say, what the healthcare professionals can do, empower the patients to become their own, to take control over their health, really. I do have a YouTube channel which is called Be Your Own Doctor. Of course, you know, it's not supposed to be taken literally, but what I mean by that expression, be your own doctor, is in between the doctor's visit, if I'm seeing you in my clinic every 3 months, in between those 3 months, I'm going to educate and empower you so much that you will be able to look after yourself, be your own doctor until you come and see me in 3 months later. And I then put you on the new path as far as the care of your chronic conditions is concerned. The patients come to a clinic, we have 10-15 minutes, we do quick prescriptions, investigations, and we send them on their way. My approach is different. I sit down and actually explain what exactly is this condition, how is it going to behave in the next year, 5 years, 10 years, what are these medications, how you need to tweak the doses and frequency of the medications depending on the weather, depending on seasonal flu illnesses, and so on and so forth. There are so many variables. It is not normal to give a medicine with a certain dose and expect the patient to be taking that medicine in the same way 12 months a year. The simple example is water medications and hot summer. Water medications usually given for heart conditions, mostly for heart failure, swelling of the legs, and so on and so forth. They dehydrate you. You don't have to be a doctor to realize that. How can you take the same dose of a water medicine in winter when it was -5 this morning, and in summertime when it was +40 recorded last summer? It's not rocket science. It's a water medicine. In winter, there is one dose. In summer, when it's really hot and you are more likely to get dehydrated, that dose needs to be reviewed under the care of healthcare professional. This is not happening. This is not happening. The first thing to understand is to accept your mortality. One of the problems I find with the patients and families is this living in denial and not wanting to talk about it. I turn it completely upside down and I explain and practically demonstrate how discussing end-of-life care now will actually help you to live longer, better. If you are diagnosing a long-term condition such as dementia, Parkinson's disease, heart failure, COPD, emphysema, as doctor, as healthcare professionals, nurses, we know the trajectory of that illness. We know these are inevitably conditions which life expectancy is limited, and there will be loads of bumps, ups and downs during the course of that disease. So it is naive to diagnose a dementia, even if it's just a mild dementia now, not to sit down with the patient and actually tell them what this disease looks like. And of course, that journey will be individual for every dementia patient, depending on what other underlying health conditions they have. But it is important to start end-of-life care discussion at the time of the diagnosis. one of the reasons I believe dementia patients die earlier than they would have done otherwise are recurrent hospital admissions for minor concerns, which could have been addressed in the community. And of course, you bring a dementia patient into hospital, the unfamiliar environment precipitates delirium, and the delirium is a killer. And it fastens the dementia, it accelerates the dementia, and that person with dementia probably will die earlier than they would have done if we had that discussion and planning at the beginning of the diagnosis. I use every minute, every instance I come across the patient to communicate the long-term messages. I treat the problem which is acute today, but also take an opportunity to educate about that. So communication, 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 face-to-face teaching, but also the presence on various channels. So I have my YouTube channel where, in fact, in the last months, I posted 2 videos talking about dementia and dementia-related problems. For healthcare professionals, during the pandemic, I worked tirelessly, day and night almost, for 2 years, and put together a masterclass in practical geriatrics, which is the course for healthcare professionals. We have over thousands of students, mainly UK-based. When I say students, I mean healthcare professionals, doctors, nurses, pharmacists. It's not just for doctors or for nurses. It is for geriatric multidisciplinary team, and it is CPD accredited. So it's a 30 CPD points, and you can, once you sign up to the course, you have the lectures, the PowerPoint presentations for life. Then the Instagram channel, of course, I do regular discussions about geriatric related subjects with Trisha Goddard on Talk TV. As you can see, I'm using every opportunity to get these messages across, and hopefully your listeners there will benefit from this as well.